Hello, everyone, and welcome to today's live broadcast, Modified Dental Composite for Bone Repair. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by GIBCO by Thermo Fisher. GIBCO Cell Culture Heroes is a program putting PhD and postdoc researchers around the world in the spotlight. For more information on our sponsor, please visit thermofisher.com/Cell Culture Heroes. Now let's get started. I would like to remind everyone that today's event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. You can also see at the top of the page multiple tabs. Please click through our related applications, upcoming on-demand webinars, as well as links to the Cell Culture Heroes webpage. You may be our next cell culture hero. Also, please notice you can share this webinar on your personal social media. Just click on the social sharing tab to let your friends and colleagues know about today's live event. Now, if you have any trouble seeing or hearing the presentation, click on the Support tab found at the top right of your presentation window, or use that Ask a Question box to let us know you're experiencing a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of your presentation window and follow the process to obtain your credits. I would now like to introduce today's presenter, Mayda Arshad, PhD student at the University of College, London. For a complete biography on Mayda, please visit the Biography tab at the top of your screen. Welcome, Mayda. Thank you for joining us today. You may now begin your presentation.
Thank you, Christy, for that introduction. So today, hello everyone, I will be talking about my PhD project, which is on modified dental composites for bone repair. So a quick outline of what I will be discussing today. I will be talking about the osteoporotic treatment, how it works, what's out there already. In terms of what's already out there, I will be discussing the risks associated with the treatment of osteoporotic fractures and how I'm addressing these problems, these risks and limitations with my project. And then I will briefly go over some future projects I'm interested in. So osteoporotic bone is the result of a decrease in bone density. We can see the difference in the bone's microarchitecture between the healthy bone and the osteoporotic bone in these figures. Osteoporotic bone has an increased risk of fractures which often occur in the spine. These are referred to as osteoporotic fractures. With age, the risk of fractures increases, and this is due to the reduction of the mineral density, and as well as the increased rates of fall among the elderly. And because there is an increase in the elderly population, better management of this condition is required. It's also a huge burden on the medical system, especially in the UK and the NHS. So better management would benefit the costs that go into treating these patients as well. The current treatment for osteoporotic fractures is vertebroplasty and kyphoplasty. In kyphoplasty, a thin catheter tube with a balloon at the tip is guided into the vertebra. The balloon is then inflated to create a cavity in which liquid bone cement is injected. The balloon is then deflated and removed, and the bone cement is then injected into the cavity. Vertebroplasty is a procedure in which bone cement is directly injected in the fractured vertebra, and the cement hardens within approximately 10 minutes. At the Eastman Dental Institute, various dental composites are prepared for tooth fillings. So my PhD project is looking at using these composites for bone repair. So the most current commercial product is polymethyl methacrylate. I'll be referring it to as PMMA during this presentation. And in the market, there are about 14 types of PMMA. PMMA is the most commonly used bone cement currently. However, there's a list of problems that are associated with this product. Manually preparation is required prior to surgery. The setting time is too slow. Heat is generated during the setting time. So normally it comes in a paste form, powder and liquid. When it's mixed with the paste form, and then once it starts to react, it starts to solidify. That's the aim of the product, but however, during this process, a lot of heat is generated, and it's damaging to the surrounding site of the fractured site. Also, there's a mechanical mismatch. Often it's too stiff in comparison to the bone it's being treated on. And as a result, because of the setting time and the material, the components of PMMA, this can make the material very toxic. And again, setting time can lead to leakage. And a lot of clinical studies have shown patients to have bacterial infections. And with this product, there's no successful antibacterial action. Another form of bone cement is calcium phosphate cement. Now, these cements consist of calcium phosphate to help them sort of be very similar to bone, because our bone consists of calcium. And also, these cements are porous. The cells like cements to be porous to allow integration. However, this compromises on strength. Also, they have a shorter setting time compared to PMMA, but this then also compromises on their strength, and the mechanical strength is not very strong. And again, there's been unsuccessful antibacterial action. So the general aim is to develop a low modulus and high conversion bone composite that provides bioactive and osteoconductive properties for orthopedic applications. We want a quick setting bone cement upon injection at the fractured site. An osteoconductive material will present osseointegration where there is formation of a direct interface between an implant and bone. Figure A is a representation of a normal joint. We can see the invertebral disc between the bones, and the red circles are representing the blood vessels. Figure B is a failed fusion where a fibrous capsule has been formed between the bone and the implant. This is a typical situation often seen post-op between polymethalmethacrylate PMMA and bone after a vertebroplasty procedure. Figure C is the desired outcome we are hoping to see using our composite, where the implant and bone have a direct interface. So the problems I'm addressing in my PhD are the preparation technique, setting time, heat generation, mechanical and chemical mismatch, and toxicity. So looking at the preparation technique, most commonly commercial polymethalmethacrylate cements require a bit of equipment. You get a powder form, which then needs to be mixed into a liquid form, and then is taken up using a syringe and then applied to the patient using an injectable syringe. Our composite doesn't require any of these steps. Our composite can be directly applied to the fractured site using a double-barrel syringe, where the double-barrel syringe consists of two separate components. They're pressed at the same time, pressure is applied, and they're both mixed via the automatic mixing tip, and our paste is ready to start the reaction, which I will discuss further in the presentation. So the composite components, why our composite requires a double-barrel syringe. The double-barrel syringe is required because our composites are very similar to tooth filling composite, where light is required to cure the paste into a solid. Our composite cannot be used via light cure. One of the obvious reasons is because it's applied inside the body, and it will be difficult to apply UV light within the fractured site. So we have an initiate and activator phase. Once mixed, that's what starts the paste to set into a solid form. The initiator and activator both consist of bulk monomers. Their role is just to act as a carrier. They also, it has a high molecular weight chemically, and due to its structure, it increases the conversion time, and it's less toxic than other monomers that are used. Another monomer, PPGDMA, HEMA, it acts as an adhesion promoter, very commonly used in dental composites for allowing fillings to attach to the tooth. Again, here the idea is that bone is similar to tooth, so it will allow the composite to bond to bone. Also for meta. So the difference between the two pastes that go in the double barrel syringe is BP, the initiator, and NTGGMA, the activator. Also, what's important about a composite, one of the components, is that they consist of monocalcium phosphate. These allow remineralisation, which means the composite will release components that in chemistry are very similar to bone, and this will allow integration with bone. We've also added polylysine. It's a very common antibacterial agent in food products, and we're hoping that this will work as opposed to antibacterial or antibiotics, because there's a lot of resistance to antibiotics at the moment, whereas in polylysine this has not been seen. So to control the first problem and setting time, we want to see if we can influence the setting time. And we can do this by decreasing or increasing the levels of BP and NTG-GMA. I kept the ratio the same at 5:3. I broadened this range to see how much of this could be influenced by keeping the ratio the same, with increasing levels of BP and decreasing levels of BP also. So once the initiator and activator mix, due to a free radical reaction, this starts a chain reaction that joins the single monomer molecules together in long linear polymer chains. Once these have formed, the second dimethacrylate cross-link the polymer chains into a network. The level of reaction can be monitored using Fourier transform infrared spectroscopy, and the C bond O peaks shift during polymerization to a lower wave number due to its change in its vibration frequency, indicated in the circle. So upon activating the polymerization of a monomethacrylate, such as PMMA, there is a rapid reaction, and like the animation just shown, the formation of a long polymer chain. However, often when you use a monomethacrylate, you have some unreacted monomers within the chain, which cause leakage, which is a problem with the commercial PMMA, later leading to toxicity. These problems arise in the commercial products. However, our composite consists of dimethacrylates, where after 50% monomer conversion, there is a second reaction, like we've shown in the animation, and that the chains cross-link. So thus 50% is required to ensure no free potentially cytotoxic monomer can be released. So the specific wavelength we know is within the specific region, and the spectrum changes over time. I convert this into a graph looking at the change of spectrum over time. On the y-axis, we have a degree of conversion, and on the x-axis, we have time in seconds. From this, we can see in the first graph on the left where the FTIR analysis was run for about an hour, and the decrease in initiating activate delays the monomer conversion by approximately 30 minutes. Hence, the final conversion for formulation M2 is not really representative of the composite because it's still reacting. And then we can see with M3 there is no conversion, confirming that these levels are obviously very low and far too low for the formulation. The second graph on the right shows an increased range of conversion options for the composite, where inhibition time is also varied. Now, the inhibition time is the pause before the reaction sets off. The assay shows we can manipulate the inhibition and conversion based on the desired outcome, which will inevitably depend on how much time the surgeon needs to inject the composite into the vertebral fracture. The monomer conversion time desired by surgeons also varies depending on their experience. The formulations allow for controlling the level of conversion by changing the levels of BP and NTG-GMA, where we can see on the graph on the right by increasing these components. We can see this obviously also reduce inhibition time, and you need to sort of weigh out what's desired. Do you want a longer inhibition time? Does the surgeon want a shorter inhibition time? Or what do they prefer ideally? Higher the final conversion, the lower the risk of leaching unconverted monomers, which poses less toxicity risks to patients overall. Furthermore, during this reaction process, I mentioned heat is generated. So using a differential scanning calorimeter, the heat generated during the polymer conversion was measured to compare between our formulated composite and the commercial PMMA. So the difference in heat generation was 4.3 degrees Celsius, and according to literature, temperatures of surrounding bone composite where they are exposed to PMMA can exceed 70 degrees Celsius. Now, the amount of heat generated, if you want to calculate it, is the area under the curve, and larger volumes of the material will inevitably generate more heat. Here, only 0.47 grams of material was used, and normally in a clinical setting, approximately 10 grams are used, so a lot more. Moving on to looking at the mechanical and chemical mismatch. So this is a table describing the tensile strength and the modulus of cortical bone and cancellous bone. Now, our bone consists of cortical and cancellous bone. It's a combination. It's brittle and it's ductile. So it has the spongy part of the bone, and it has the hard part of the bone, which we're familiar with. The tensile strength is the maximum stress that a material can withstand while being stretched or pulled before breaking. And the Young's modulus is a measure of the ability of a material to withstand changes in length when under lengthwise tension or compression is applied. The best way to describe this is if you imagine having a piece of a plastic ruler and you snap. So you're looking at how much strength it has before the ruler snaps. Modulus is about the material's elasticity. So if you have an elastic band, if you pull the elastic band and let go, you look at the ability of the elastic band to go back to its original form. I've also added the commercial PMMA in comparison to the tensile strength and modulus, and you can see it's very different, and we want to find something that is close to bone. So to test this assay, I prepared 10 millimeter discs in diameter and 1 millimeter in thickness. They were placed in 10 milliliters of simulated body fluid and were left to incubate for 4 different time points. Using this assay, I looked at 4 different properties. The mechanical properties where I looked at ultimate tensile strength and Young's modulus, and to look at the chemical properties, I assessed remineralisation and component release. The ultimate tensile strength was assessed by applying load to the discs at a certain speed until the discs would fracture. This is a typical stress strain curve, and this shows on the graph what is happening when load is also referred to as stress is applied to the disc. When the disc fractures, the fracture point is registered. So here is a graph showing the change in ultimate tensile strength over time in the different formulations with varying levels of monocalcium phosphate and polylysine. If we look at the x-axis, the first 2 groups consist of 8% monocalcium phosphate, and the second group consists of 4% monocalcium phosphate. Within the high and low levels of monocalcium phosphate group, we also have high and low levels of polylysine. The first group has the highest amount of monocalcium phosphate and polylysine, and the last 2 groups have the lowest amount of monocalcium phosphate and polylysine combined. We can see from the graph, after 1 month, the tensile strength decreases in all the groups, and also increasing levels of monocalcium phosphate and polylysine decrease the tensile strength overall. Getting the right proportion of monocalcium phosphate and polylysine is important. We want to make sure the material's tensile strength is optimum to prevent fractures post-surgery. This graph is showing the Young's modulus. The Young's modulus, as I mentioned before, is the measure of the ability of a material to withstand changes in length when under lengthwise tension or compression. Ideally, we don't want this also to be too different to bone, and we can see the Young's modulus can also be influenced by increasing or decreasing the levels of monocalcium phosphate and polylysine. So if we refer back to this table and add the ideal combined formula, we can see the lowest level of NCPM and polylysine gives us the tensile strength at 90, better than PMMA and modulus at 2.3. Now, low modulus is also a good thing because it tells us the material has more elasticity. If a material has a higher elastic modulus, it means that its stiffness is strong, but permanent deformation is likely. A lower modulus material will mean it's more pliable substance that exists versatility on mechanical characteristics. Such a substance is actually good for the spine due to the daily movement and orientation. Now, to look at the chemical mismatch, I did the same assay, leaving my 10 milliliter disc and 10 milliliters of simulated fluid for 4 different time points at 37 degrees. To explain a little bit about remineralisation, the reactive calcium phosphate in monocalcium phosphate particles, these are produced upon neutralizing phosphoric acid with calcium hydroxide. Calcium and phosphate ions precipitate from acidic solutions as plate or needle-like dicalcium phosphate crystals, depicted in the figure in the slide. In neutralizing body fluids, however, the dicalcium phosphate will transform into balls of hydrophobic apatite crystals with a porous honeycomb-like texture. This is what we hope to see with our material, allowing bone integration, because the bone is also very porous. The hydrophobic apatite crystals have a similar calcium to phosphate ratio to bone also. Thus, the remineralization of the composite will allow better integration with bone, as well as healing the fractured site. Here are the two groups with 8% monocalcium phosphate and varying levels of polylysine over a period of 1 month. Images are taken using a scanning electron microscope. And the first image at the top for each group is what the disc surface looks like prior to being placed in simulated body fluid. The images on the left for each group are low magnification, and the images on the right are high magnification. And here is the same time period for the groups with lower levels of monocalcium phosphate at 4% and varying levels of polylysine. Again, we can see in both groups the formation of some sort of layer on the disc over time. So we can see in all the groups that over time, there is some sort of layer that's being formed due to the components within the disc, and of course, what's in the simulated body fluid. And this is mimicking a clinical setting of what may happen to this composite when it's inside the body. Ultimately, the highest level of monocalcium phosphate and polylysine show the ideal physical appearance of hydroxyapatite after 1 month. And you can see that there was this layer on the disc and it's cracked, and you can see the ball-like features and also some needle plate-like features as well. Finally, looking at component release. This is important during remineralization because we don't want complete acidic conditions. Also, especially when our composites will be in an environment where cells are to be recruited for healing. This is a graph looking at the release of hydrogen ions versus square root of time. And the graph shows us that with increasing levels of monocalcium phosphate and polylysines combined, the material releases more hydrogen ions than the lower monocalcium phosphate and lower levels of polylysine combinations. This needs to be studied further and assessed because such conditions will influence the cell environment for cell culture studies. Also, my next step is to assess the polylysine release independently itself and to see how much is released over time, since we're trying to see if this will play a big role in antibacterial action. So the final problem I'm trying to address is toxicity. To do this, I did some primary cell studies where I placed the discs in the cell culture media at 100 rotations per minute for 24 hours. At the same time, I seeded 30,000 cells per centimeter cubed for 24 hours in a 96-cell plate. After 24 hours, the media from the cell was removed, and the media in which the discs were submerged in, that media was added to the cells. This was then left for 24 hours and assessed via Modulus. So on this graph here, we can see the metabolic activity of the cells based on what they were exposed to. So the first two groups are the high levels of monocalcium phosphate with varying levels of polylysine, 5 and 2, and then the next two groups with 4% levels of monocalcium phosphate with varying levels of polylysine. And then the last two are the extracts from the commercial PMMA and a control well. And we can see at 24 hours and 7 days how the cells responded. The extract was collected after 24 hours and 7 days. So two different types of extracts the cells were exposed to. And we can see that the cells that were exposed to the composites with higher levels of polylysine were lower than the composites with lower levels of polylysine. So we believe that too much polylysine isn't always good for the cells. And I'd like to add also, often polylysine is actually used to plate some materials that are used for cell attachment, often to encourage cell attachment. At the same time, the study shows that maybe too much polylysine may not be great for the cells, but further analysis needs to be done on this. We also just was interested to see the cell morphology what the cells look like. Are they happy on the material? The image on the left is a image from a scanning electron microscope image taken where cells were attached to the disc, and also staining with DAPI and colloidin was done to see the presence of cells just after 24 hours. And the cells show they're spreading out and they're happy and they're flat. So this is a good sign that our material creates conditions where cells will be happy to stay. Finally, I did an ex vivo study, and this is where I used a CAM assay. Here you use a chick egg, you incubate it, and at day 3 you window the egg. You create a window. Day 7 you add a graft, and in my case, the graft is my composite disc. And then you collect images, and at day 14 you then collect the graft. Instead of combined formulations, I wanted to see if individually the discs releasing anything will pose any damage or are toxic at all. So I had composite discs with no polylysine and monocalcium phosphate, the lowest level of polylysine at 2%, highest level of polylysine at 10%, and 4% at monocalcium phosphate and 16% monocalcium phosphate. This is what the chick embryos look like prior to adding the graft. So you can see the window in all the groups of eggs I used, and you can see the vascular system of the chick embryo. It looks healthy, it looks red, it looks fine. The chick embryos are fine too. Over time, I assessed how the chick embryos developed, and finally at day 14, when I collected the graft, the membrane was attached to the disc, so it shows the disc created an environment where the membrane of the chick embryo was happy. And I took some images on a scanning electron micrograph for these, and we can see red blood cells, we can see cells. So this is a pilot study as well, so we need to assess this further and see what we're seeing, why we're seeing what we're seeing. For the highest level of monocalcium phosphate, at 16%, we actually noticed on the disc under the scanning electron microscope the physical characteristic parents to the hydroxyapatite, the ball-like structure, suggesting that in this environment, the discs were able to remineralize, not too different to what may happen in the body. My next step is to then add discs and combine formulations, as I've been doing the other assays with, where I've got monocalcium phosphate and polylysine both together in the discs, and add these to the CAM assays and see what they do, whether they remineralize or whether they work well for the chick embryos as well. So in conclusion, in terms of preparation techniques, ours is definitely easier than the commercially available cement. The setting time we can influence, we can optimize, and it can be manipulated easily. Our material also generates less heat than the commercially available cement. A lot of work still needs to be done, but our material is closer to bone than the commercially available cement, and the material has shown the ability to remineralize. In terms of toxicity, the cells are attaching and present and active with the material, showing that the material has angiogenic properties because of its success in the CAM assay. The ideal material will then have, as a result, if it's osteogenic and angiogenic, it will be able to play the role of a fused implant. Future projects I am interested in doing further with these materials is looking at cell migration, cult culture with an osteoblast and osteoclast, and see how they interact with the material, and also investigating if these formulations encourage cell differentiation. I'd like to acknowledge my professor, Anne Young, my secondary professor, who was Gordon Blunt previously, and now my secondary professor, Patrizia Ferretti, and everyone else in the lab and hospitals who have helped me, who have provided me with the cell samples and material and all the guidance that I've had. Thank you so much.
Thank you, Mayda, for your informative presentation. We will now start the live Q&A portion of our webinar. Now, to our audience, if you have any questions you would like to ask, if you haven't done so already, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many of your questions as we have time for. Okay, let's get started. We have so many great questions already coming in. Wow, okay. Mayda, let's start with this one. You compare your composite to the PMMA. However, what makes your calcium phosphate composite different to the already existing calcium phosphate composites?
Okay, so like I mentioned, there are several calcium phosphate composites available in the market already. What makes our composite different is that it's actually already been tested in a clinical setting for the teeth. So we know it works very well with the teeth. And the current calcium phosphates that are available, there's limitations, and we believe that our composite has an advantage because we're addressing these limitations, and hopefully our composite has an edge because it has the antibacterial action within it. Hello?
Hi, Mayda. I'm so sorry. Let me repeat that. What are the low and high magnifications used in your graphs and photos?
Oh, in the, I believe that question's for the scanning electron microscope. So there was various magnifications used. The main magnification, I was going up to 10,000, and lowest was about 250 mag.
Thank you. In your pardon me, is your in vitro experiment, does it take into consideration the microenvironment in the mouse?
That's a very good question, actually. So my in vivo experiment actually doesn't do that. These composites have their experiments that have done for in clinical trials for the use of dental composites. Those tests have been done, but my experiment doesn't. But it would be important to note that there is a lot more bacteria and chances of infection in the mouth, in the oral cavity, as opposed to an environment within the bone. So there's less chances of secondary infection using the composite in the bone.
Very good, thank you. Our next question. In your ex ovo experiment, what were your visual observations besides electronic microscopy findings?
That was a very good question. There wasn't anything out of the ordinary. In looking at the ex ovo experiment, you normally look to see how well the chick embryo develops, if there's any terminations, if the embryo survived. I did look at the branching. So when I took the camera images of my discs with where you can see the blood vessels, just looking at how many branches, this indicates how well the material encourages angiogenesis. I'd like to further look at other ways of assessing how good it is, but apart from that, I didn't do anything else for now.
Thank you. Our next question. Have you tested whether this composite would interfere with MRI or MRS scanning signals for imaging purposes?
No, I haven't. Although it shouldn't, but that's a very good question. And if you'd like to reach out to me, I could actually get back to you because that's not something I've looked at.
Thank you, Mayda. Our next question. I'm curious that you have some data related to particulate leaching over the period of time, and if so, what would be the consequences?
So looking at what the leaching out of the material can be good, is good and bad. We want material to slowly be released from the material. Like I mentioned, we have monocalcium phosphate, and the release of this would encourage remineralization of the disc so that the physiology and structure mimics bone so that it can allow bonding with the bone. We also want polylysine to be leached out, to be released slowly for its antibacterial action. However, obviously, if too much is leached out all of a sudden, it will change the pH. It can make the environment acidic, and it can kill the surrounding cells. It can also We don't know yet how, but it can trigger an immune response. It could trigger inflammation. So these things are important to look at, and we need to be able to assess what parameters are good and how much material should be released, but that needs to be looked at further.
Mayda, how did you characterize the mineralized material HA by XRD or FTIR? Sometimes salt also is absorbed on the surface.
That's a very good question. That's in progress at the moment, so that's not something I've done.
Okay, thank you. What are the rationale for the selections of 4% and 16% MCPM?
So the rationale was that 16% would be the high end, so that's the most amount of monocalcium phosphate that's being added. We don't intend to add that much in our composites, and 4% being the lowest. So it just gave us a range, especially for the CAM model, just to see if anything, if a high range at that level would be toxic to the chick embryo or not. And we saw that it wasn't.
Mayda, over time, regular dental calcium composites deteriorate, and over time they must be redone. How do you plan to prevent the deterioration within the bone?
That's a very good question. So the idea is that because our composite remineralizes, it may not require the composite to be redone, because that's actually a big problem. A lot of procedures, a lot of patients that undergo vertebroplasty, it has to be done again because you get adjacent fractures, or there's an infection, or due to wear and tear, the composite has deteriorated. So we would like our composite not to have that consequence after it's used on the patients. And the best way we aim to do that is to have a composite that actually remineralizes and actually encourages new healthy bone to be formed.
Mayda, how different is the application of the composite in healthy bone in comparison to osteoporotic bone?
So it's actually the same. Osteoporosis doesn't actually affect the healing process. So if you have a fracture, it will still heal in within about 6 to 12 weeks. So the idea is that this composite will help.
Mayda, what are the chances of the body's immune response responding to the composite?
So there's actually a really good paper that talks about how the immune response has actually helped with the composites having monocalcium phosphate, how the immune response actually helps encourage stem cells to differentiate to bone cells. And most composites that are used, such as polymethyl methacrylate, they have compounds that leach and they trigger an immune response, which can be problematic for the patient. But this is something that I am very interested in looking at, to see how the immune response and how the immune cells actually interact with the composites components.
Thank you, Mayda. And we have time for one last question. How does polylysine in your material work as an antibacterial?
So it has some advantages. It is generally recognized as a safe status because it's used for a variety of food applications. It's known to encourage cells to proliferate. It can disturb the bacterial membrane integrity, affecting their gene expression. And so that's how it's known to sort of have that antibacterial action. It also enhances our composite's water absorption, and this promotes the release of antibacterial agent from the the composite itself.
Thank you, Mayda, for this informative Q&A. Do you have any final comments for our audience?
I don't. I'd just like to say thank you so much to everyone who's tuned in today. And I would like to acknowledge my team once more at the Eastman Dental Institute, especially my friends who are also scientists working with me, Nazanin, Tarleen, and Zalika. I would also like to give a huge thanks to my husband. He is my greatest support, and my mum and my family who go above and beyond, especially helping me with my kids. And I'd just like to say, if you would like to reach out to me, you can go to my biography tab, and then you can visit and click my LinkedIn and Instagram.
Thank you again, Mayda. Now, before we go, I would like to thank our audience for joining us today and for their interesting questions. There were a few questions we weren't able to answer today, so those questions we were not able to answer live and those that are continuing to be submitted during our on-demand period, they will be addressed by Mayda via the email address you provided at the time of registration. I would like to once again thank Mayda Arshad for her time today and her important research. We'd also like to thank LabRoots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. You will now be redirected to the registration page of our next webinar titled Unveiling the Role of T-Cell Dysfunction in the Development and Progression of Glioblastoma by Dr. Felipe Galvez-Cancino on June 18th at 9 a.m. Pacific Time, 12 p.m. Eastern Time. We hope to see you there. Stay healthy, and we hope to see you again soon. Bye-bye.